Okay.
Please start.
Okay. Good morning, everyone. My topic for today's discussion is management of congenital cystic eye using various sclerosing agent. And it's a rare ocular malformation first reported by Taylor and Collis in 1906. In 1939, Edmund was the first one to coin the term congenital cystic eye or an anophthalmos with cyst. It can be microphthalmos, anophthalmos, or it can be combined. So, the basic pathology behind the congenital cystic eye is arrest in the invagination of primary optic vesicle. If it occurs in the 2 to 7 mm of stage, it leads to anophthalmic eye. And if it occurs in the 7 to 14 mm of stage, it leads to microphthalmic eye. Cyst occupies in the central orbit in case of anophthalmos, whereas it occupies inferior orbit in case of microphthalmos. As name indicates, histopathology showed some amount of normal ocular development in microphthalmic eye, whereas it's not in anophthalmos cyst. Diagnosis is basically pure clinical, and it's a non-tender cyst present either in a central or inferior orbit, non-pulsatile cyst with or without ocular structure. Sometimes it might be progressive. Pediatric referral has to be done to rule out any ocular anomalies or systemic anomalies. USGB scan and MRI to done to rule out any other pathology associated with that and to know the exact location of the cyst. And a principle behind the intervention is to keep the cyst as long as it's necessary to adequate socket size. The ideal age is 5 years, and early intervention is needed in case of small cyst if it is unable to retain the conformer. In case of large cyst, it is a socket becomes too large, difficult to accommodate the conformer. And earlier, before 2000, surgical excision was the only option. Later on, sclerosing agent came into the place. These are all the various sclerosing agent in which we are using ethanolamine oleate, bleomycin, and fibrin glue in our cases. So the study was done over the period of 2008 to 2023. We included 7 cases in which 2 with the ethanolamine oleate, we used fibrin glue, and in 3 cases we used bleomycin. This is the first case in which we used ethanolamine oleate, in which 0.3 ml of ethanolamine oleate was injected. Resolution of cyst was noted 6 weeks. And conformer of increasing size was advised for the patient. And this is again the same patient after the injection. And this is the second case in which fibrin glue was used. Again, the cyst which occupies the inferior orbit, transilluminant, with a shallow fornix. And after the cyst aspiration, we injected a fibrin glue of 1 ml. And at the third post-op day, it was completely resolved, and fornix formation has been planned later. So this is the first case of bleomycin, in which again inferior orbital cyst, with this MRI picture showing the cyst which is extending till the apex of the orbit. We aspirated 15 ml of amber colored fluid, and after the 20 international unit of bleomycin was injected. And in between, the patient lost follow-up, and he came after 6 months, and later on we injected a second injection. And after the second injection, it was completely resolved, and formation was also done, and the conformer is placed. So this is one more case in which we used a bleomycin, and again it occupies till the whole orbit till the apex of the orbit. And this is after the first injection. The patient had a swelling again, so we have injected a second injection, and later on the cyst has completely resolved. And overall, we used in 7 cases. We have given a sclerosing agent, out of which ethanolamine oleate is a cheap drug, but it's not easily available. Whereas in the fibrin glue, the duration of resolution was 2 to 3 days, but it's very expensive. The bleomycin is the cheap drug, but the duration of resolution is 6 months in this case. So if the cost factor has been eliminated, fibrin glue is the best sclerosing agent that can be used, and in otherwise, bleomycin is the best with the cheaper availability and the duration of action. Thank you.
Are you using any device like CT guided, ultrasound guided?
No, sir. Basically, the diagnosis is full of clinical. To know the extent and the location and the site of the cyst, we have used MRI. And after the injection, we again order MRI after 4 weeks. And we'll look for a resolution of the cyst is there or not. So if at all resolved completely, we'll go for a further management. And if not resolved, we plan for the next injection.
Sometimes you are aspirating.
Yes, sir. We are aspirating.
The best tool is to aspirate. To aspirate, then you can use ultrasound guided. Very easy.
Yes, sir.
And
Ultrasound can
the
be done.
ultrasound we can make
ultrasound guided. Ma'am, in the first case we used ethanolamine oleate. In that case, with the one injection itself, it resolved. Like later on, it's a very huge cyst in which the shallow fornix was noted, and it obscures the whole orbit and till the apex. So in that case, it necessitated the three injection maximum we have given, and we have followed up over the every 4 weeks, and the patient after 2 months also has recurrence has occurred.
Other cases you did not.
Ethanolamine oleate didn't present with recurrence. Again, with fibrin glue also didn't present with the recurrence. Bleomycin had, and but the cheaper and easy availability make it used in all the cases. Thank you, sir.
How does it act actually?
Sir?
Sclerosing agent. What is the action?
Sir, and the ethanolamine oleate, it actually creates an inflammation and endothelial thrombosis it creates, and thereby it causes sclerosing. Whereas in fibrin glue, again it is a coagulant, it contracts the tissue. Once the aspiration has been done, it contracts the tissue. Bleomycin, again it acts by creating a fibrosis and inflammation.
Okay.
Thank you, sir. Thank you.